The best thing I ever heard was someone said, why do we have so many people that are specialized in bringing people into this world, but yet we don't really talk about guides leaving? With hospice, a lot of it is answering these questions that we don't really talk about, things that people are afraid to discuss. You know, that's the best part about this, is you guide people through.
We still get the odd person who asks how much it's all going to cost. So, hospice is free. That's why we fundraise so much. You do not have to pay for our services. We don't want anyone to miss out because they think they can't afford it.
I'm Andrew Johnstone, and this is The Last Breath, a podcast about death and dying, a free FM production made in association with Hospice Waikato. In this series, I'm talking to the bereaved, the dying, and the people who care for them. And as we explore the work of hospice, we are lifting the veil from a subject that is seldom addressed in an open and forthright manner. This episode is all about the work of the palliative care nurse. Kevin Tardiff and Sarah Clunie talk about their work caring for those who have reached the end of their life journey.
And I remember I was younger, I think I was 13, and that was hard for a second because we thought that it was very blunt. But as time went by, that was the most appropriate way to say it. You know, and you can say, oh, you know, he's in a better place, or all the different platitudes people use. You know, I have seen where it can make people confused, and then it gives them this sense of hope for a sec. It's best to just explain what's happening. And that was, at a young age, I remember that being very important to never say, oh, they've passed on, or we're reaching the final stage. It's so confusing. What does that mean? And as you say, you know, to say, we're dying, that's okay, because we're all going to do it. You know, there's this, one of the things I always struggled with, I don't know, I haven't experienced it here so much, but in the States people saw it as seen as a battle. We need to fight this. We need to fight this. How do you fight death? That's, when you look at something so inevitable as a battle, then we're all going to lose. And that's not a good way to see death. You know, it's just we all are going to do it. And again, that's why I joined hospice, is instead of being afraid of it, I think it's good to have a guide through it. Again, saying the word death is important, but it is scary for many people, again, because I think we're also sold these bill of goods that as long as you do treatments, as long as you do this, we can prolong, but no one ever discusses what prolonging means. That could be you're in extreme pain for an extra 3 months. Is that your goal of, you know, is that your goal towards the end of your entire life? And I think education on that is important. My name is Kevin Tardiff. I am a community nurse with Hospice Waikato. I am fairly new with the community here in New Zealand. However, I did this job for 3 years in the United States. And upon coming to New Zealand, I'm very excited to be a community hospice nurse.
Now, you were in the Peace Corps.
Yes.
Well, you were dragged into the Peace Corps because your wife wanted to be in the Peace Corps.
Yes.
So that was, your option was to wait for her in the States or join her in Morocco. So you went to Morocco with her. And you were, what was your profession at that stage?
So for Morocco, how the Peace Corps works is the country invites you, you interview for the Peace Corps, and then the country sees the applicants and then they invite you over. My wife is a teacher with English as a second language endorsement. So technically they invited her, and I was what was called special skills, which means I think I was just kind of baggage. But at that time I was doing wildlife research. So while my wife was teaching English, I attempted science clubs. When that didn't work, I built a computer lab. I didn't have internet, so that didn't work. And then it slowly just turned into believe it or not, it was board games. I started doing board games with kids, and that ended up being extremely successful at this youth house. And that was what I ended up doing. Though it wasn't monumental, it was appreciated, and I enjoyed my time.
And then you had a revelation.
I did. I was asked to go out to the Atlas Mountains with another volunteer to do basic first aid training. I had never done it before. They gave me a crash course on blood pressure, temperature, all these very basic things. When we got out there, we started taking care of people and just, again, doing these basic first aids. And I was so fulfilled in just that one day. People were so appreciative of just basic care that after that, I couldn't get out of my mind that I wanted to do healthcare. And it slowly evolved to, once I got back to the States, I quickly, got into nursing school, and best decision I've ever made.
So what happened when you graduated from nursing school? What was your first appointment?
My first job was I was a nurse on a chemotherapy floor, so an oncology unit. And even though it was oncology, it was a mixture of medical, surgical. We kind of were the overflow. And that actually was a good lead into hospice, because in our city, we actually had an infusion center. So how it went is, if people had a fairly good diagnosis, they would just go to the infusion center. If they came to us, their diagnosis wasn't very positive, and we did have a lot of patients who had died, and that was definitely the first introduction towards end of life for me.
Did you find that a place where you felt you belonged?
With oncology, it absolutely was. I really enjoyed the work. There was just the type of people who chose that position as well, just were more relaxed, I felt, had a good sense of humor, and definitely felt that I fit in. How my hospice journey, though, it's not as romantic as I would like it to be. My son was starting kindergarten, and I needed to start an hour later so I could take him to school. And it ended up being hospice they had a position. They started an hour later, and then I could, again, take my kid to school and then go to work. And it ended up being the best decision. So it was an accident, but I don't want to go back. I was on this kind of precipice when I was making this decision. I had this desire to do intensive care, do that, ICU, all that stuff. Or I thought, or I could also go this path of end-of-life care, hospice, and I wasn't really sure which way I was going to lean. But when this job opened up, I went towards the hospice care, and it fit better than what I was expecting. And I've come to realize that it is something that I value very much. And I didn't know it until I went into it. There's a lot of nurses that had a calling, or they felt a passionate drive, and I kind of just fell into it. But yet, how fortunate. It ended up being exactly what I want to do.
Why?
Why do I want to do end of life? The best thing I ever heard was someone said, why do we have so many people that are specialized in bringing people into this world? You've got all these midwives, you've got these doctors that specifically do pregnancies, but yet we don't really talk about guides leaving. And I know that's such a simple thing, but that stuck with me for a long time, and I realized that's what I wanted to be. I wanted to be that missing piece to kind of demystify death, because we just have so much on this life coming in, and yet I wanted to help.
So you see yourself as a guide?
In a sense, I think with hospice, a lot of it is answering these questions that we don't really talk about, things that people are afraid to discuss. That's the best part about this, is you guide people through. I never like to feel that I'm telling people what they need to do, and I don't tell them what foods they have to eat, what drugs they need to take. I just kind of help guide them through what they want, what they chose. And that's why, again, hospice to me is ideal, because patients have a lot of say in how they want to die. Not when, not where, but where they want to be. And I just really like being able to help them through that.
So, what did you learn as your time as a hospice nurse in the US? What stories have you got to share with us? What insights?
For me, the best thing I learned is you kind of have to do, again, what the patients first and foremost want, and then you also do what the families want second. It's not about me. I will say I had a situation that stressed me out and still causes me a lot of flashbacks that make me uncomfortable, but I had to be okay with it. I had this patient whose grandchildren were very important to him, and he really, really wanted them to be with him as he was dying. And I felt that that was a good idea, and I wanted to support that. The family was on board. However, I got a call from the daughter that he was dying, and they wanted me there. So I drove over there, got out, and I went and checked on him, and he was actively dying. He was surrounded by probably 12 of his grandkids screaming at him, "Papa, don't die, don't leave us." And to me, that was very stressful. And my first and foremost was, no, he needs to leave him alone and be quiet and let him just die in peace. But I had to remember, it wasn't about me. That was what he wanted. Though I was hoping the kids would have said other things, it was still important, and we made sure that when he died, he was surrounded by everyone. And that was just, that was a big step for me in realizing that it's not about me. I have to just do what they want, what the family wants, what the patient wants. So.
That's interesting, because even though he's in his last few moments of life, would he have been cognizant of what was going on around him?
You know, they always say hearing is the last sense to go. And so, yes, I would think that he would at least hear his grandkids.
Would he be experiencing their distress?
That's a good question. I don't know. That's the one thing I will say about death is it still has a lot of mysteries to it. Without asking him, I have no idea.
Your response would have been my response, would have been, let him go in peace. I would be worried that he'd be hearing this and it would be making it for an uncomfortable exit.
Absolutely. Yeah, it's definitely one of the things I have the hardest time with is when people are dying, everyone sees it as this losing battle. And with his grandkids yelling at him, "Don't go, keep fighting," I was worried that I don't want him to think that he's letting them down, because he's dying, and that's what we're all going to do at some point. But again, I don't know if it passed on. He seemed relaxed, and I was happy with that, and the family they were extremely happy how it went down, but I hope more than anything that it was how he wanted to go.
I think it would have been good for the children too in the long run, because often we shield children from certain realities.
Yes.
And I think it's very important for children to understand the actualities of life.
I agree. It's interesting when we try to hide it from kids, because to what end? At what point are they now ready to learn about it? I feel, in my experience, a lot of times when kids are part of the process, they handle it way better than the kids who are isolated. Kids who are isolated are scared, they want to know where their loved one went, and I mean, it's not for me to say how the family does it. However, I do prefer, in my experience, when kids are informed and part of it, because then not only are they feeling left out when they're not told, when they are aware of it, they interact with their loved ones differently, I feel. And I think it is appropriate. But again, this isn't just kids. I can't tell you how many family members the patient is actively dying, and they still want to know what we can do. And yeah, I think we need to discuss death more. Just basic education. And also stop pretending that it's not inevitable.
And it's not always good, is it? Death is not always comfortable and easy.
No.
And I think, as hard as that is to acknowledge, it is part of the dying process. Sometimes it happens, the patient is relaxed, accepting, and other times it's a different story. There's a lot of pain involved, there's a lot of distress.
Yes. Yes. But again, that's why I love hospice, is that's, I guess you can never really say how someone will die, how they're experiencing it, but at least we're not ignoring it, and we're trying the best we can. I feel very fortunate in home hospice. I actually, in all the years I've done it, I could probably pull out 2 times where I felt someone was actually in a lot of pain and there wasn't much we could do. And that's pretty good for, yeah.
How do you cope with a bad death? Somebody who's not accepting of what's happening, complicated family situations. How do you, as a palliative care professional, deal with difficult situations?
No, that's a really good question. I think even, gosh, I've done this now 3, 4, I'm up my 5th year for hospice. I still ask myself, what is my coping mechanism? When I was younger, my dad was a veterinarian, my mother was a nurse practitioner. One thing they always were really good at was they never brought work home. Ever, ever, ever. It was always, they would discuss things if we asked questions, but they never came home and, they were parents when they got through the house. And I sometimes feel that is how I process, is my family is the way I deal with all of this. And, when I come home, I try not to, I leave it at work. And it's not that I'm covering it or hiding it, it's just very clear boundaries. And I think that gives me time to process when I'm not actually thinking about it, if that makes sense. I'll be with my family, and then there are times where certain people will come into my memories and I think about them, and I'll wonder if I did it right or if they had good deaths. But that's where colleagues are very helpful, because I think it's important to talk to them about how you feel. And they're definitely people who understand. It's hard to talk about death with people who aren't familiar with it, especially friends. They'll try their best, but you don't want to put it on them, right? So family and colleagues are the best way.
What's the worst part about your job?
For me, the worst part is making a promise that I probably can't keep. I feel that with end of life, with death, I want to do the best I can for my patients. And sometimes emotionally you want to take care of them, but it might not be what we're able to do. Maybe we can't do certain meds, or just be it anything that I wish I could do for them that's not possible. That's the hardest part. I don't want to let anybody down, especially because this is such a hard time for everyone. So that's the hardest for me.
What's the best part about being a palliative care nurse?
Again, the best part is giving people help through a hard time. I think about one of the main reasons I became a nurse was, as I said, in the Peace Corps, but also my mother had what was called Guillain-Barré. And what ended up happening is her body started attacking her nerves. And so she was in the intensive care unit for, oh my gosh, 5 months. And it reached a point where certain nurses would come on and we would be so happy because we knew she would be taken care of, she would be in a good mood. And then there were some who, when they came on, you're disappointed because you knew it was going to be challenging for my mom. And so for me, the greatest, I feel good when people seem happy I'm there because I know then their loved one is comfortable. They are comfortable. And that to me is the best.
What's the heart of nursing?
Ooh. I don't know, that's a good question. I think about this a lot. I hear a lot of people, again, say that nursing's a calling and they feel like it's their identity, and that's great. I wouldn't say this is my identity. Even though I love what I do, I wasn't called into it. But to each person, each nurse, I feel they have their own heart. They have their own idea of what's important. So I guess I feel uncomfortable giving such a broad statement on the heart of nursing, because also nursing can be pediatrics. It could be, there's so many different fields. I don't feel I could give you a good answer and feel satisfied with it.
Well, here's another way of phrasing it. What are the emotional qualities that make a good nurse? You're talking about your mother. There are obviously some nurses who lacked certain qualities of empathy?
Yeah, empathy, absolutely. I see some people who come in and then they just want to do their tasks. And yeah, you do your tasks, you can keep people comfortable physically. But if you're not emotionally available to them, if you can't stop for a second and just talk to them and actually see how they're feeling, not just look at their numbers, that to me makes a better nurse. And I guess maybe that is the answer to what heart of nursing is. Definitely compassion with boundaries, because there's always the other side. I've had a couple colleagues who I would say, it seems silly to say unless you're witnessing it, but are almost too compassionate and can, if anything, it harms them and it harms their care. They can get too invested, too emotional, and they struggle. And then I see that they struggle taking care of others if they give too much of themselves. There's definitely a fine line between empathy and also professionalism.
Let's talk about some of your experiences. You spoke earlier about the gentleman and his grandchildren. Do you have any other stories to share, Kevin?
In the States, I had taken over another nurse's team of patients. And she had one that was deemed difficult because she did whatever she wanted to do. She was on oxygen, but she would smoke. She would only take the meds she wanted to do. And it was constantly like, go in, go out, da-da-da-da. And when I first had her, I was taking the advice of this other nurse and was trying to make these short visits. And it just something felt wrong. The more I was visiting other people, I kept thinking, why aren't I taking more time for her? Why am I listening to what this other nurse said? So instead of this desire to do these tasks, tell her what to do, follow all these things, I ended up just sitting with her in her living room, talking. Half the time we watched Bonanza. It was a cowboy. I knew nothing about it, but she loved it. It was always on. And I would say for the first 2 months, that was all I did. I'd sit down, because I'd make sure I had the same time, same day, and we would sit for about 30, 40 minutes watching Bonanza. And after that, our relationship really got a lot better. I think there was a level of trust that formed from that. And all of a sudden, she became my easiest. We'd go in there and we can talk about anything, and she just, all the things that everyone, she will do whatever she wants. all of a sudden we had a dialogue. We had a, friendship's a hard word because you want to be professional, but we definitely were understanding of each other. And that was another example of why I love this job, is it wasn't me just being this authoritarian. I just came in and then I was someone she ended up trusting from a cowboy show. And so did I have that with anybody else? No. But that's what I love, is each person's their own unique story. And that's the best part about a hospice nurse, I feel, is adapting to the needs of the person. Before I moved out to New Zealand, I started getting a lot of working at this memory care facility.
What is a memory care facility?
They specialize in patients with dementia. And it's very challenging there because, again, here I talk about my last person where it's important to form a connection. This is the complete opposite because it's literally impossible to form a connection. They don't remember you. And so, again, you have to really adapt to the person. And each visit feels like the same introduction, the same. You're at that very base level, but you're still trying to manage them at the same time. But the story I was going to say that I remember and appreciate is it was a very rare situation where usually when a patient comes into this facility, the family, if they have to stay at home. But this husband and wife, the husband, he didn't have any memory issues, but it was so important for him to be there. So they allowed him to be in her same room, which, again, unheard of. So I took care of his wife, and he was very protective of her, and in a good way. It wasn't, but questions after questions, and I actually thought he wasn't too keen on me because of all the things, kept looking over my shoulder, and I just really felt like, all right, I'm going to do the best I can. I hope he feels comfortable with me, but I never really got that. Then his wife ended up dying, and then he was put on hospice, and he requested me to be his hospice nurse because he liked me, and that was such a, again, another one of those, each person is different. And I ended up being his hospice nurse, went through his entire journey until he died, and I don't want to say satisfying, but it just felt nice that I was so afraid that he didn't feel his wife had died well, but yet he must have been very happy with that care if he requested me. And so that to me was something that really stuck with me.
Well, to finish up, Kevin, personal perspectives on death and dying. You're around death all the time. It's your profession, and I take it, with the passion you've been speaking about it, I take it you're going to be doing this for a long time yet?
Yes.
What lessons have you learned, and what are your own personal thoughts and feelings about your own death?
Ooh, that's a very good question. First and foremost, the lessons I have learned is I am now more open with talking about it with friends and family. Not that I just go out of my way. When people ask me questions about my job, I would try to pull back. And even though I do feel like they might not understand how I feel, it is still important that I want more people to understand that death is okay. I really want to demystify it. One of the hardest things I struggle with is when, again, I don't know about in New Zealand, but in the States, there's the idea that if people keep eating and drinking, that's the only reason why if they stopped those two, that's why they're dying. And just it's important that I just continually educate people, but again, only if they're open to it. I don't want to go out and just start talking about it. But when it comes to my own death, if anything, it's made me think about it less because I don't know what will happen. There's so many ways people can die in the hospital, instantaneous, prolonged, that it's made me just realize what's going to happen is going to happen. I actually, if anything, I think about it less, and I'm less afraid of it doing this job.
So my name is Sarah Clunie. I am one of the community nurses here at Hospice Waikato. I originally come from Hawke's Bay and I did my nursing training in Palmerston North before moving up to Hamilton. I have been a nurse for 10 years now and at Hospice Waikato for 5.5 years. And I am going to be here for quite some time. I love it here. I love the vibe that comes with working here and the work that we actually do. I worked in a bank for 9 years before I became a nurse. Yeah, I just got to the point, I think, in banking where it wasn't what I wanted to do long term. It wasn't, I suppose, there wasn't the passion there. I looked into a few different options, such as St John or the police, and had a couple of flatmates at the time who were doing the nursing degree and thought, well, I keep wanting to talk to them about what they're learning, so why don't I just go and learn it? Yeah, and that's kind of what got me into it. Getting into palliative care nursing was very much probably an emotional response. My family had quite a few family members go through hospice down in Hawke's Bay over the years, including my mother and my grandfather, who were passed away, died about a year apart from each other. So there'd always been a bit of a correlation with hospice. And while I was district nursing up in the North Waikato, I would work in collaboration with the hospice nurses. So I got a little bit of a taste of palliative care and kept umming and ahhing about it. One of the nurses here was like, there's an opening, have you applied? And basically badgered me for about 3 or 4 weeks to put the application in. So yeah, Jenny from the rural team did that and I applied, got the job and haven't looked back. Yeah, palliative care's, it's quite a different kind of nursing. You're not aiming to fix things. You're aiming to manage symptoms and make people as comfortable as possible, but just walking alongside them. And that's something I tell all our new patients that I see is, we're not here to take over. We're not here to tell you what treatment you should or shouldn't have or what medications you should or shouldn't have, but we're going to walk alongside you right till the very end and be as involved or as uninvolved as you want. It's still very much about giving them control, because when you're sick, especially with something like a cancer, you lose so much control over what's happening to your body, what's happening to your mind, what you physically and emotionally can handle. Yeah, some people really find that probably the hardest part. And that's what I just want to reassure them, is saying, that's what I'm there for. It's just to help you navigate everything. Be an ear if you need it. You know, be the bad person if you need it. I'll say to people, especially when someone is approaching end of life, and you know, there's usually a lot of people that want to visit, pay their respects, and sometimes it's just too much. And I just say to them, tell them the hospice nurse said no. You don't have to make that decision. You don't have to sound like the bad guy or the bad daughter or son. You tell them the hospice nurse said no. It's one less decision to make. Yeah, I have had one patient where, unfortunately, we do end up with multiples in the same family over the years. So I had one patient a few years back in Cambridge who, lovely guy, used to get on really, really well with him, loved going and seeing them and having chats and everything, and he slowly started deteriorating and got to the point where he was in bed most of the time and becoming more and more unresponsive. And he was awake one day when I got there and he said, oh, can we just have a chat? I said, yep, sure. So everyone else filed out of the room, was sitting there, and he said, what's happening to me? And I thought, okay, time to practice what you preach. And instead of saying things like, you're getting sicker or you're slipping away or you're going to pass away, I just had to look him in the eye and say, John, you're dying and you're probably going to die soon, like within a week. And he looked at me and he said, okay. I said, do you have any questions? Or thinking, now what do I say? And he said, can you just get my wife? And I said, 100%. I said, you let me know if you need anything else. So I went out to the lounge, told his wife, and she went in. And then emotions just completely took over and I lost it there in the living room. Full on face, tears, sobbing, which was a first. Usually you can hold those emotions like we all have a bit of a cry, and I'm the first to tell my patients, I will make you cry. It's not coming out of meanness, it's just that I always make people cry. It's just an emotional time. But it had never happened to me in a house in front of family members who were actually the ones going through that. So after much apologising, because I felt horrendous, we sorted it through. He had a really peaceful death. He probably did only last within that week, but it was nice, it was calm, family were around, and he was just slipped away nicely. And then a few years later, I've had a couple of role changes in hospice, and I have also managed the Rainbow Place team before I went on maternity leave. Once I came back from maternity leave, I came back into community adults, and one of my first patients was this man's wife. So, as I said, it's sad when we get more than one from the same family, but it's also nice in a way that you know the family. I knew what her husband had been interested in. I was able to go in and talk to her about him and keep his memory alive while she was dying as well. So, and I knew the daughters. You know, I'd had interactions with all of them, including falling apart in the lounge. You wonder sometimes when someone's passed away or died a couple of years later, you sit there and think, I wonder how they are, I wonder how things went afterwards. So it's nice in a way to be able to see those people. It's sad whenever anyone has to come through hospice, but I think that's the nature of it. We are there for people who are dying. It can get quite hard sometimes, you get quite attached, and I think having been through it with my mum, it gives you a different sense of how they're feeling. I always believe that, experience makes good nursing. So if you've had experience in a particular area, you can relate to people and their journey a bit easier. And I always find that if I've got families with children that were around the age of myself and my siblings when we lost mum, that I can give them a bit more insight as to what they might be going through, what they might be feeling, what helped us. I had a patient who had a teenage daughter, early teens. She was really struggling with all the things she wanted to do and leave behind for her daughter, and because she was young. So we used to have big chats about what I had found good. You do draw a line as to how much you let people know about yourself when you're the nurse, because you do have to have boundaries. But there's some patients, I will open up a bit more, like this particular lady. And it was good because we were able to spend some time helping her prepare and get things she wanted for memories for her daughter. And she actually passed away on Mother's Day one year, which, again, emotionally throws you completely. But I have since seen her husband and daughter out and about, and she's doing great. She's a gorgeous young lady who is just amazing. So it's really neat knowing that you've helped keep her mum's memory alive as well. So I've never worked in a hospital or in a facility. I've always been a community nurse, so visiting people in home. And I will sing the praises of community nursing to anyone that listens. When you see someone at home, you get a completely different and understanding of them than you do when they're in a facility or a hospital. In a house, there's always something to talk about because they'll have art on the wall, they'll have collectibles, they'll have photos. So you can sit there and talk to them, and you just see them light up when they can talk about themselves and what's important to them. We still get the odd person who asks how much it's all going to cost. So, hospice is free. That's why we fundraise so much. You do not have to pay for our services. We don't want anyone to miss out because they think they can't afford it. And everyone, we give you all the same. You need a wheelchair, there's a wheelchair. It's just so nice to be able to go into a house and just see the difference you're making. And if someone wants to die at home, to try and do everything you can to do that, to enable that, is, it's lovely when it all comes together. There are times where unfortunately it just doesn't work. the care becomes too much, it becomes unsafe, and then we look at other options, but it's all done alongside that patient. Yeah. I had a patient who didn't have family, so we do a genogram, which is like a family tree. His consisted of himself, his dog and his cat. And I thought, now this is going to be interesting. So he was a bit of a nomad. He lived, I'm not sure if it was in like a house bus or something, but I always met him at his friend's place. Lovely, big, spacious home. They used to host exchange students and everything. And I'm talking to him one day about end of life, and I said, have you given any thought as to where you would want to be or how it's going to look? Because as much as we'd like to, it's not going to be able to happen in the house bus. And he said, oh, my friends have said I can stay here and they'll look after me. And I'll fully admit that judgment in my head took over, and I thought this could turn completely wrong. It's quite a big task to look after someone at end of life. And I couldn't have been further from the truth. It was one of the nicest end of life scenarios. His friends were absolutely amazing. They stepped up. It was like he was part of their family. He had a lovely end of life with his dog, with his friends, and they did an absolutely beautiful job.
Brings to mind, a very important question, and I've heard this discussion a lot. What's going to happen to my pets when I'm gone?
Yeah, it's always hard. That particular man, I know his friends kept the dog. I presume they kept the cat. I think she was well and truly well ingrained in that house. Sometimes that is a bit of a barrier for us getting patients into our inpatient unit, or even getting patients to go up to hospital, because who's going to look after my pets? Who's going to feed them? Who's going to be there for them? If I'm not there, what are they going to do? I had it myself, but there's been stories where animals have been adopted by other hospice staff, or when I was district nursing, we had the same thing. A lady was dying, and one of the nurses adopted their dog. He's very much well and truly alive. He's lovely. It's usually the little things that are what cause the most stress. I haven't organised all my books or my papers. I had a lady just recently who said, I feel like I want to go through all my drawers and organise things because I don't want to leave it for everyone else to do afterwards. I did say, well, you could pick one or two drawers, but energy-wise it's going to take quite a bit. So sometimes it's getting people to look at it from a different perspective as well. Let's use your energy on good things rather than the mundane, I need to tidy that drawer.
When it gets complicated with families, because families are complicated things, and when it does get complicated, how does that work for the people who are caring for the dying person?
More so in big families, the complexities come in because there's so much love towards the patient, but there's so much worry as well, and that emotional distress about what's happening. Are they feeling okay? And sometimes one of the hardest parts for us as a nurse is we'll have 2 or 3 or 4 different family members all trying to get the same information but not really communicating well. We always find it easier if there's almost like a spokesperson. Otherwise, we've had it in the past where we've had 3 family members ring up stating the same problem, and we've given advice to one and then the next one, and we're thinking, are you talking to each other? Or just, so it's helping them navigate communication as well. And we have said in the past, look, it's easier for us to deal with one person. So if you guys could think of that, not to say that you can't ask us questions. By any means, everyone can ask us questions. We're there for everyone. But it does get quite intense when there's a lot of family members all asking you the same thing all the time. And one of the other complexities is when you've got, I suppose people are at different stages of grief before death. You'll have some family members accepting of it and aware that this is what's happening. Mum, for example, is dying and we're just keeping her comfortable. And then you'll have some who haven't quite got to that point yet and still want, there must be something else we can do. There must be something we can fix this. And it's just trying to help them navigate that and accept that we've actually got to the point where there is no more treatment. We gave her any treatment, it would just make her sicker. chemo. Lovely thing when it works, horrible to go through. But some people will push and just want more treatment. But it's just knowing when to say there isn't any. And that's always a hard one for patients to hear as well. And I suppose I'm thankful in some ways I don't have to deliver that conversation very often. Sometimes you have to help them understand it, but I'm not the doctor that has to say, we're done, there's nothing else. Because to me that seems like it's quite final, and that must be quite hard for those doctors, and really hard for the patients to hear, especially when they've got all this hope and then it just gets pulled out from under them.
And this is a very interesting point, because through the course of this series of interviews, we've heard a lot about people who have good deaths, but there are people who don't have good deaths, and people who don't accept what's happening.
I personally think that the ones that don't accept what is happening have the not so good deaths, because they're almost fighting it the whole way. And hope's a really powerful thing, but I think sometimes that hope turns into a bit of anger that this is happening, and they're almost trying to refuse it happening. And that, as I said before, that loss of control is just, it sort of takes over. And I suppose if you're angry about something, you're all tense and worked up. So therefore, you're all tense and worked up right at the end. Whereas to die comfortably, it's better to be sort of relaxed and accepting. It's a really hard one to get a person to that point if they're really not accepting of it. And I can't think of a specific example, but I guarantee there's patients I've had where they've been like that and they just have not wanted to die.
Which is a natural reaction, of course.
Oh, absolutely. I mean, you may know it's happening, but it doesn't mean you want it to. It's such a hard thing to come to terms with the actual end. And I suppose, like, everyone always asks, how do you then approach it yourself? I'm a little bit very just pragmatic and just like, it'll happen, worry about it then. I mean, I've got the things like, a will in place, but I'll have to put my hand up and say I don't have an advanced care plan, and it's basically because I just haven't got around to doing it, even though I'll tell everyone they need them. I know what certain wishes are, and my family are aware of those wishes, but our family is because we've had so much death in our family, we're very, I suppose, pragmatic again about it all. Just the other week I had a relative say, is there anything of mine that you want when I've died? We've had this discussion, I've told you what I want. Just those sort of material, tangible things. But it's one thing that she can do to prepare so she feels organised. And me and my siblings are very open about talking about it, and it'll happen one day and we'll worry about it sort of then. I don't think working in palliative care has changed my view on life, I suppose. I'm aware that life can be short and come out, the end can come out of nowhere, but I just kind of keep going and keep living and do what I want to do.
You worked with a paediatric palliative care.
Yeah.
Tell us about that.
There's not as much death in paediatric palliative care as there is in the adults. The cure rates for children are really good, and our palliative team, Rainbow Place, deal more with life-limiting conditions. We had a couple of deaths during my time, and it's always hard. I think having worked with death and dying patients for quite some time, I probably am able to just compartmentalise it, and then, as I said, I have those emotions afterwards. I had my little boy quite early, so we were in the hospital for about 3 months after he was born in the intensive care unit. So then when I came back, when I was due to come back off maternity leave, I had to sit there and think, having had him so sick, can I go back to dealing with sick children? And the answer was no. So I spoke to the team here and said, look, can I go back into adults? I don't think I could do the Rainbow Place team justice by not being able to emotionally manage a sick child, especially if it was a baby. I just thought you can't really have a manager who can't step into the unit up at the hospital because they've got anxiety or anything like that going on. So that's why my journey's a little bit different. I went into paediatrics and then came back out. You've really got to protect your own emotional wellbeing in palliative care. You've got to know what your triggers are, what your boundaries are, and yeah.
So as pragmatic as you are, and you have to be stoic in this job, and you've got to have boundaries, but you're still a human being.
Absolutely. And the last thing I wanted was to have my work affected so much by my emotional situation. And as I said, I wouldn't want to feel like I wasn't providing the right care to someone or the right guidance because my emotions were proving to be bigger than that patient at the time. I even found it when I came back into the adults. I came straight back into the community team, but found that I felt like I was just getting a little bit too attached to some families, and it was just trying to navigate that again, being back at work, having a child, managing those emotions, which change after you become a mum anyway. So now I actually do almost a split type of role. I do the community nursing, but I also do our coordinator role 3 days a week. So that's in the office, just taking all the incoming calls. So I don't actually have a primary load. I sort of float, and it just helps me do what I enjoy doing, helping people through that journey, but not getting quite involved and emotional at this stage. The hospice team here, they're so good at looking after us. I always feel really well supported. When I first started, within 2 weeks, I thought, yeah, this is the place for me. Everyone would, like, you're brand new, you don't know anybody, but everyone would stop and not just say hi as you're passing in the corridor, but stop and have a conversation and actually be genuinely interested in how you are, who you are, what you're doing. Yeah, it's just, I can't sing it enough. Praise is enough, I love it here.
Well, to finish up, Sarah, what advice have you got for families who are suddenly confronted with the fact that one of them is going to die very shortly?
Yeah. Don't be afraid of hospice. We're there to help you. Pain and symptom management. Don't be scared of those drugs that have a bad name, oxynorm, ketamine, all that. We use them properly. We use them as they're meant to be used. We don't want you to be in pain. We want people to be comfortable so that you can enjoy whatever it is you want to do. And we've got options. So one pain relief might not work, or it might make you too drowsy. We can try something else, but just don't be scared of us.